Welcome back, ladies and gentlemen. Please take your seats so that we can begin. I am sure you've had a revitalizing tea break. Our next segment is a session that focuses on mental health, a subject that is too often left in silence, a topic that is very close to my heart and is also the fulcrum of my work. We are honored to have with us as chair Dr. Pierre P.M. Thomas, PhD, Assistant Professor, Institute for Public Health Genomics, Department of Genetics and Cell Biology, Maastricht University, the Netherlands. Please welcome him on stage amidst applause, please. I also call upon stage the speakers for this session, Dr. Kirk Tickell, Assistant Research Professor, Department of Global Health, University of Washington. May I please ask you to welcome Dr. Kirk Tickell. I have it. Okay, for this session, we will also have Ms. Rashmi Singh chair this along with Dr. Thomas, because we were missing her in the last session. She is the IAS Secretary, Department of Women and Child Development, Government of NCT of Delhi. Please welcome Ms. Rashmi Singh. And I see that Dr. Jitendra Nagpal is here. Welcome, sir. He's the Senior Consultant Psychiatrist and Program Director, Expressions India. I'm also inviting Dr. Cyrus Mugo, Senior Research Scientist, Kenyatta National Hospital, Kenya. And Dr. Patty Gonsalves, Project Director, Youth Mental Health Group, Sangat, India. Before we begin, just a reminder that the speakers will be given 12 minutes for their presentation. After the 10-minute mark, speakers will hear a bell, which will indicate that you have 2 more minutes to close your presentation. Thank you so much. Over to you, Dr. Thomas.
All right. Hello and welcome, everyone. I would like to start off by congratulating those of you who are still with us, both physically and mentally. Congratulations. Of course, also congratulations to Sukaria for putting together such a wonderful program that I believe we've all enjoyed. So as was rightfully mentioned, this session will be on mental health. It is often a topic that faces a lot of silence and a lot of stigma. So I really would like to utilize this session as an opportunity to raise our voices and speak freely, and also get inspired by each other's work, by examples from all of the countries where the panelists are from, in order to learn something and of course try to bring it back to the community. So it'll be my pleasure and my privilege to serve as your chair today. And as we move along, I would like to introduce and of course welcome Dr. Kirk Tickell from the University of Washington to tell us about maternal mental health. Dr. Tickell, the floor is yours.
I'm going to move the box so I don't look like a giant. Okay, so hi, my name is Kirk. I would like to start today by just extending a massive thank you to Mira and the Sukaria team. Today's been wonderful. We've actually been working with Sukaria for the last 2 years since the last conference. It's been an incredibly rewarding partnership, and we're really, really grateful for everything that we've been able to do together. However, today I'm not going to talk about the work that we've done with Sukaria. I'm going to talk about some work that begun in Kenya and then has kind of expanded to include other countries internationally. So we started this journey in a rural county of Kenya called Migori, and what we saw looking at the hospital's data is that an enormous number of children who had wasting, who were malnourished, were passing away. So up to 20% of those children were dying on the inpatient unit in Migori. And we were very, very, very shocked by that. So we began to reach out to friends, first of all in Kenya and then across sub-Saharan Africa, saying, are you seeing the same thing? Does this happen in your setting as well? And what we saw is that it did. So there's a meta-analysis in the middle here that looked at data from across sub-Saharan Africa and found that 24% of children with severe malnutrition pass away. We then went on to talk to colleagues in Asia as well, and they saw lower mortality rates, but they still felt that the case fatalities they were seeing were far, far too high. So we were very fortunate to bring this collaboration together with funding from the Gates Foundation into a network called the Childhood Acute Illness and Nutrition Network, which began in 2016 and recruited over 3,000 children in 9 different hospitals in 6 different countries across sub-Saharan Africa and Asia. We were aiming with this cohort to understand why is it that these children with malnutrition die? What are the kind of primary drivers and what are the modifiable drivers? So we recruited at admission to hospital. We skewed the recruitment towards malnourished children, although we had some non-malnourished children for comparison as well. And we followed all of the children for 6 months after their hospital discharge. And these are our results. So here you can see going across the axis time from admission, and all the 3 lines represent a group of malnourished children, the red line being the severely wasted children, the blue being the moderate, and the gray line being the non-wasted children. So in the first few days here, you can see what is the inpatient period for most children, and there's steep increases in mortality during this period. However, after the children go home, the mortality continues, particularly for the severely wasted children and the moderately wasted children, but a little bit for the non-wasted children. So we felt it was very, very important to understand what is driving this additional child mortality. We collected very detailed data about the socioeconomic status of these children, the clinical history that they've gone through, the biological data. We have done multiple big omics panels to try to understand the mortality. And this writing may be a little hard to read at the back of the room, but at the top here we have post-discharge mortality. And what I want you to take away from this bottom half of the graph initially is that we looked at many different relationships between all different types of vulnerability. And what we found, interestingly, is that while many factors work through malnutrition, childhood malnutrition, and childhood severity of illness, one factor that we found to be an independent and strong predictor of mortality was maternal mental health. So maternal mental health in the post-discharge period wasn't operating through malnutrition and it wasn't operating through severity of illness, and yet it was still a strong predictor and a strong direct influence on the outcomes of the child. So here, we looked at chronic health conditions, for example, sickle cell disease or thalassemia in many of our settings. We looked at the child's nutrition itself. We looked at household level risk factors, including their assets, or also looking at water, health, and sanitation. We looked at access to healthcare. And while all of these things were important, they tended to work through childhood malnutrition or through the incidence of severe illnesses. However, the mental health was working kind of independently of all of those factors. We were motivated then to take a deep dive on what is going on with these mothers' mental health. So we looked at their mental health whilst they were in hospital and compared it to mothers in the community. And we found that mothers in the hospital had 2 times the prevalence of mental health disorders to a mother in the community. And this was true at every site individually. So it was true in Bangladesh, Pakistan, Kenya, Malawi, Burkina Faso. Everywhere this was true. However, 45 days after discharge, many of those symptoms that they were experiencing in their mental health had resolved, and the prevalence of mental health conditions returned to the community baseline. So what that tells us is there's a lot of acute stress, which is very intuitive. If your child is sick and you're having to spend 5, 6, 7, 10 days in a hospital, that leads to a lot of acute stress. That doesn't diminish the importance of those symptoms and of that experience, because that acute stress was still a predictor of mortality. It still appears to be a modifiable target. We tried to map out, well, what is driving the poor mental health of the mothers, and there were some interesting factors. So many of the times, the mothers themselves were also unwell, so children admitted with diarrhea. It is possible other house members, including the mothers, are suffering from similar conditions. Mental health problems were also much more prevalent if the mother was pregnant at the time of their hospital admission, understandably. And we saw many of the kind of traditional risk factors as well. So a lack of social support here, represented by being unmarried, being uneducated or undereducated, and the mother being stunted herself were strongly associated. And as you can imagine, there were some markers of the child's illness as well that were important. So if the child had HIV, or if they were severely wasted, that made the mother's mental health a little bit worse. Interestingly, children who were diagnosed with malaria, their mother tended to have an actual better mental health picture. In many of the settings we are working in, malaria is a very common and well understood condition and is also very responsive to treatment. So mothers felt perhaps a little bit more positive about that. There's many different academic diagrams that we can put up about why is maternal mental health this strong independent predictor of the childhood outcomes, but it's actually quite intuitive. We ask a lot of mothers in the post-discharge period. We're asking many of them to change breastfeeding practices. We're asking them to come to clinic, often from long distances away. They have to give antibiotics, they have to give micronutrients and other medications. They have to give ready-to-use therapeutic foods if the child is wasted. We're asking them to engage in play therapy and psychosocial care. And then we're saying, look for danger signs and bring their kid back if they have danger signs. So we are asking a lot of mothers during that time, and it's easy to imagine that if they're having mental health conditions, it's extremely difficult for them to deliver all of those care aspects. This is something that we've been extremely keen to intervene upon. Maternal mental health wasn't the only factor that was associated with this excess mortality that we've seen. So we designed the COSAM trial, which is halfway through at the moment. It'll finish next year, so watch this space, which is testing a package of interventions, including new RUTF, new antibiotic prophylaxis, and importantly, a psychosocial package. And we're working across 3 countries, Kenya, Zimbabwe, and Zambia. The psychosocial package, which is specifically targeting maternal mental health here, is based on a friendship bench approach. So friendship bench was was designed in Zimbabwe by this psychiatrist, Dixon Chibanda. So he observed that the mothers who have lots of social support do quite well. So he invented this bench where he trained grandmothers at that time, but you can use community volunteers, to sit there and provide a cognitive behavioral therapy-based approach to counseling mothers. So essentially what they do is they get the mums to list the problems that they have, and then to prioritize which problems would make the biggest impact to their life and their child's life if they solved them, and then to come up with ideas themselves for how these problems could be solved. This approach has been wildly successful, so it's expanded far beyond Zimbabwe. There are hospitals in New York that are doing this, there are hospitals in London that are doing this. I would be shocked if there's not friendship bench being deployed in India and certain facilities as well. We are coupling that friendship bench approach with some additional education given around kind of a UNICEF framework for appropriate childhood development. There's a second project that I wanted to tell you about outside of COSAM, which is just starting, where we are perhaps controversially, rather than saying we're going to target build a package of many different things to deal with all of the complex social and clinical things that are happening for these children, we are going to try an unconditional cash transfer instead of that. And in that approach, which is funded by the Gates Foundation in Kenya, we're saying, what if instead of doing this, all of these different interventions at all of these different times, what if we just gave caregivers $300 when they leave hospital? Which in Kenya is a reasonably substantial amount of money. Many of the caregivers leaving hospitals in Kenya are experiencing financial hardship because of the hospitalization. And we believe that filling the gap that hospitalization has left may encourage them to come back to hospital and may allow them to access resources in the community that they otherwise wouldn't have been. So my kind of take-home messages that I'd like to leave with you is that maternal health is a direct determinant of childhood health outcomes. It's likely to be modifiable. And child hospitalization, the period of time that children are in hospital, is a valuable opportunity to deliver interventions like Friendship Bench. Friendship Bench itself is a low-cost intervention that is quite easily scaled, and it may help these mothers. We're testing it in our trial and looking forward to sharing those results with you in a year or a few years' time. But it already has strong evidence in many populations. Thank you all.
Thank you very much, Dr. Kirk, for showcasing these data-driven and evidence-based approaches to the complex web of issues that impacts women's health and mental health during pregnancy. Our next speaker is Dr. Jitendra Nagpal, who joins us from the Institute of Mental Health and Life Skills Promotion here in New Delhi. Dr. Nagpal will help us decode the adolescent mental health leadership for change and empowerment. Dr. Jitendra, floor is yours.
Thank you, Dr. Thomas. Wonderful being here. Thank you, ladies and gentlemen. And oh, it's not required. Thank you. It's a supreme honor to be here. Well, if maternal health and the child is here, then adolescents can't be far behind. And all the more a reason that adolescent mental health can't be far behind. We are a nation to about 300 million adolescents, and probably the largest in the world, as a nation having the largest adolescent population in the world. Mental health becomes an integral, inseparable component of both the discussions then. Because when we talk about adolescent education, moving to school has been a greater privilege now, and we know that the right to education is now 16 years old, and we are still grappling with the idea what makes a holistic education. In the institution where learning becomes a capacity that is unleashed by no barriers and the head is held high. But unfortunately, as we move ahead, I think I take this quote from the main works of Mahatma Gandhi when he was in jail at the Yarwada jail in Pune, that we borrow this world from children and we owe it back to them in a better shape. Otherwise, we'll have to share the blame for intergenerational dialogue. Adolescents take the future along. Mental health today, before the schooling years are over, probably is the deepest and the most difficult trajectory to identify early, intervene early, and rehabilitate early. Because it's a time when the brain is nurturing the hardware and the software of the neurons, and all the adolescent neural circuits are actually falling in place. We know that 100 billion neurons from the neurosciences as pedagogy has led us to accept that if not now, then when? Because the burden of institutional mental health in the higher education, ladies and gentlemen, you can go back today and see the Times of India front page. The Supreme Court has warned higher education institutions, the IITs, AIIMS, IIMs, for the number of suicides. The best of the best going to the best institutions and the worst of the suicides. Is it an acceptable combination? Is the IQ failing the EQ when we enter the portals of higher education? Where is it going wrong? Not that we need to just leave it because, okay, just about 2% may have committed suicides. But one suicide on a IIT Kharagpur campus, just about a month back, is the 7th suicide in the most premier institute of the country. So where was their adolescence lost in the schooling years? Do we need to decode that, unwind that? That's the whole idea. Well, if we see the childhood, as Sir said rightly, on a continuum, it does not stop at 18. We agree by law, 18 is child. But then what we carry as life skills, as positive mental health, resilience and well-being, is the whole extrapolation of life lived happily, healthily and harmoniously. And that's the gorge between adolescents and the youth of India. I was privileged to discuss a lot of such dialogues with Madam Rashmi Singh, Secretary WCD Delhi, and of course Dr. Ajay Khera is here, a great friend, philosopher. But we don't seem to be really moving with the momentum that is required, with the Gen Z population moving faster than any speed. Well, if APJ Abdul Kalam had to wake us up in his beautiful works of Ignited Minds and Wings of Fire, that do something about the mental health of children, and that's the President of India talking, he's a spaceman. Globally, I just want to share here that we hold about 1/5 of the global burden of mental illness at the moment, one by sheer numbers. We celebrate numbers and we are happy that we have the largest human resource for even adolescent care in the world. But what is the process failing in utilization, integration, inter-relationship, partnerships between ministries, between organizations? So I think it's another good opportunity, a fantastic opportunity with the national new education policy in place and also the out-of-school adolescent getting a good care from the entire ministry dedicated to them. This is a right opportunity not to underscore only, but also not ever to underplay the dialogue of mental health. That's a huge area. We have all discussed this through the day, I guess. Besides lifestyle disorders, we need to know what good India is doing. The best of the surveys being done for our own children are happening now in India. We don't entirely have to depend on global data for our own kids, including adolescents. The more than 20,000 students surveyed in this particular survey by the Ministry of Education after COVID told us enough data about mental health in adolescents. So I think we need to go back to school. Yes, I think we all need to go back to school for a change, to understand schooling better, to understand institutions dealing with non-formal education a little bit better. Because the whole plethora of disturbances turning into disorders in adolescence is unfathomable. Sometimes we don't realize that if substance use, exploitation of adolescents, rejection and neglect during adolescence, which is child rights violation, it could be done inadvertently in the family, in the society, by the peer group or by the people at my school, my teachers. But the burden of mental health disease is phenomenal. We just see that. Recently, India has really worked hard towards the idea that, okay, lifestyle disorders or the non-communicable disorders actually are taking a toll because mental health is a common factor in most of the NCDs, whether it is obesity, diabetes, hypertension, road traffic accidents, cancer, drug abuse, suicides. Mental health is a common factor. The behavioral process of change or changing behavioral process, it is mental health. Can we debate on that? We should. Why we neglect mental health as a low-lying area of NCDs when it happens to be the common factor in most of the NCDs? It's my lifestyle, the way I live, yearn and also celebrate my lifestyle. See, if we give it a standalone picture, then it has a burden. If we give it a lifestyle disorders, then it's a huge mountain to deal with. So mental health cannot be underplayed anymore. Well, we all know about the concerns of adolescence. It happens, everything happens at the same time, and never in life so many things happen at the same time. This is what the young people tell us. We're just through the mental health week in India, 4th October to 10th October. And the immense amount of, these are few posters I came across from schools. I have the burden of living with emotionality, living with the peer group, which is unpredictable. The whole idea about friends, relationships, living with a newfound sexuality on the social media, very easily, very intense, very rapidly available, diversely available, and without any background known to me about the evidence, whether it is pornography or Insta or Snapchats. The suffering part is what we are seeing is the identity. Who am I? What am I? What's my purpose? What I need to do to build a career of success, happiness. So I need to get the best marks, move into a college and be proud of fantastic packages from IIT, IIM. But then I decide to quit life. What's wrong with me? Or what you didn't give me the right while I was in school? Mental health, life skills, coping ability, resilience. Well, these are the curriculums very nicely now incorporated. So it's a suggestion that what we've been following, and the programs are picking up quite well in different states, mainly with the Navodaya Vidyalaya Samiti, the Kendra Vidyalayas and the Eklavya schools, the tribal areas in India. The four-pronged approach, what you see here in the inverted triangle, an ecosystem for universities and schools. It's both for universities and schools, more with school-directed approach. The entire institution is dedicated to, whether it's a non-teaching staff, teaching staff, parents, including the class 4 employees. They are all components of the larger component of school mental health, in terms of orientation, in terms of advocacy. Second and the third are the areas where the school counselors, the mental health providers who are working with the schools, like I am working with the large number of school systems in the country. The difficult task is to try the barriers, and the barriers could be about stigma, denial, condemnation, ostracism, and also acceptance of mind as a component of good health or well-being. Yet, but still the war is not bad because the battles have been won. The level 3 is the difficulty where the counselors, teachers, so teacher as a counselor, volunteer parents as counselors, and I'm coming to the fact that how students as first aid counselors and leaders in mental health, decoding them as the carriers, then you see the problems can be minimized on level 4. The data cannot be tertiary care burden on hospitals and clinics of adolescent mental health. We need to reduce it at the level 1, 2, 3. So when you look at leadership in mental health, this is my main part in short, it plays a crucial role in promoting mental health awareness and support in the educational environments, whether I'm in the school or in the non-formal education systems outside the schools, which a different ministry handles. If you look at these, some strategies, collaboration with faculty and teachers, training programs for students, we'll just see that in the video, and feedback mechanisms by the students, for the students and of the students. They are the leaders. We have huge number of them. You walk into an average government school in Delhi, you have 3,000 students. You walk into a public school, you have 12,000 students. So I'll just tell you, these are the life skills and well-being leadership courses now which have started from 8th standard onwards. They deal with subject matters like these. Can we have this? Is the audio on for this?
ये है वो माइंड 25 करोड़ की शोरों का माइंड जिसमें है कई सवाल, हर सवाल पर बंदी है गांठ। आओ खोलें इन गांठों को।
We had the former President of India inaugurating the adolescent mental health program led by students across the country some few years back. These are the peer educators, the peer leaders in schools.
And you know how to go at global standards and speak over there. You should know that actually what skills are needed in life, and you have to be complete in yourself.
Life skills will help us in making decisions.
We all are living in a competitive world. We all know that. And scoring 100%, there could be 10 people scoring 100%. What makes us different from other same scorers? That's what life skills teaches us.
In life skills is we get to know, okay, this is happening. Now, how can you deal with it? All the problems faced by you, you can arrange them in your mind. I will do this first, then that, and then everything will be good.
Class 10, it was when we faced the want and the need to make decisions in our life. There were academic decisions, there were social decisions, and life at school and family wasn't that.
Person is different, every student is different, every student has special skills. So the school and the teachers need to make sure that these special skills are, developed in the students.
So we must wake up. We must use this media. We must see, not look. Listen.
But that's just a sample of what students can do to lead the baton over there. So I think this is what is the conclusion. We can always discuss it further. More than head boys, head girls and prefects have people who are ambassadors for mental health, peer support systems, and be advocates for activities which are infringement on their positive mental health. These are some of the programs, festivals, Olympiads on mental health. And what you see is, let's join in solitude to reform ourselves. The power lies with them. We are yet to tap their power in the whole capacity as a nation. But I think this is a powerful mechanism to empower them and bring them to the forefront of decision making and then their policy making. So youth parliaments led by adolescents are now making a good mark in the change of the new national adolescent policy in education. Thank you.
Thank you very much, Dr. Nagpal, for your engaging overview of how we can further integrate mental health at several levels in schools and in the healthcare system. I think you brought forward a very interesting point of how, as infectious diseases come under control and we are getting increasingly better at managing non-communicable diseases, one of the major challenges that remain is mental health, and we need alleyways such as the ones introduced by Dr. Nagpal in order to get better and be there for the youth and adolescents in our respective countries. On this note, I would like to invite our following panelists to the front. Dr. Cyrus Mugo, who joins us from the Kenyatta National Hospital in Nairobi. And Dr. Mugo will talk to us further about how to integrate mental health in the community institutions in his home country of Kenya. Dr. Mugo, the floor is yours.
Thank you, Dr. Pierre. Yeah, thank you. We've had quite a bit of this from Dr. Kirk and also from the schools in India, that the adolescents have a big issue with mental health, and we've seen that in a lot of literature. What we call common mental disorders, depression, anxiety, trauma, they account for about 30% of the total burden of disease in this age group. And 75% of those, as also has been noted, in countries like ours, my country in Africa and in Asia, covering a lot of the low and middle income countries. So when we look at African youth, a lot of the studies will show that close to 40% will present with some symptoms of anxiety, depression, and post-traumatic stress disorders. But there is very low investment in mental health care in our settings. Kenya is an interesting example. We have about 60 million Kenyans, and less than 10 facilities situated, most of them near the capital city, offering comprehensive mental health care, whether it's thinking about psychiatric wards, dedicated psychiatric wards. A few hospitals will also have some beds available for persons who may have severe mental disease. And the professionals, while we've trained a few, we have less than 200 psychiatrists in the country, and only actually less than 100 in public service, meaning that it remains a very expensive set of conditions to take care of. And psychologists, follow, close behind. Very few psychologists available in the public setting. There is a special group. Kenya is in East Africa. We have a high burden of adolescents living with HIV. Together with the Southern African countries, we contribute to the highest burden of adolescents living with HIV. Our prevalence, though, our adult prevalence is going down 3% about this year, from highs of 12 to 15% experienced in the early 90s, and about 20,000 new infections. So basically, this group is still growing, and we have about 250 of them. Right now, we are taking care of in the age group of 10 to 24. And very many studies that we've conducted, summarized in a lot of these systematic reviews you are seeing here, do present with common mental disorders, about 25% in a lot of the studies that we've done. What do we see as the biggest costs of poor mental health? A lot of the studies, there are not many, but a few of the studies that have looked at the downstream effects of poor mental health, depression, anxiety, really have looked at HIV treatment outcomes for this group, that is poor treatment adherence, viral suppression, engagement in care that is poor. But there are others that we can easily associate. That is the quality of life. Very few studies have looked at that. Poor school performance because of missed school with advanced disease. Higher mortality, of course, because HIV still remains the #1 killer of adolescents. But we've been doing something in the last decade. We've had several things done. We have a mental health policy now and an action plan that we were hoping would have made a lot of strides in getting mental health care to people across the country. And this policy was also informed specific guidelines for HIV care and specific guidelines for HIV care for adolescents. But implementation is a big challenge, a big challenge. And thinking about the simple requirement to have a screening tool like the patient health questionnaire already embedded in this, in the care platforms, electronic care platforms, but it's rarely completed, and in many places you're not going to find it completed. And there are many reasons, given for this. So we talked to, providers and adolescents in a small study that we're conducting, funded by the National Institute of Health from the US. And there are two problems. One, the services are not accessible, and where they are accessible, they're very porous. So inaccessibility is really a question of a lack of resources and personnel, and the funding. The funding line for mental health is one of the smallest you'll find, for whether you're talking about the national budget or talking about the budget for the county or talking about the hospital budget. And even in families, it's the one thing that is really budgeted for. It's porous because when you go to the clinic, while the provider is trying to offer the service, they say, this is the one that I will miss. I will look at you, and if I suspect that you could be having a mental health issue, then I'll screen you. And so we keep missing people even when they come to us in the facilities. The barriers that we've seen, we could talk about structural ones. Big ones on resource, so we're not budgeting enough for mental health, very heavy provider workload. We had this big system where we started the HIV clinics, a vertical program funded mostly by PEPFAR, and the work, while the numbers have continued to increase because of survival, we've been doing very well with survival, we've not really increased that workforce. And so on a certain Saturday, when you've booked your adolescents, you're going to book 100 of them to come to the clinic, and they're going to meet one clinician. So what time will this clinician have to screen the adolescents? And there's generally a lower prioritization of mental health. And when you're in the clinics, where is the space to actually do this work? That's another big issue. How do you do counseling in a place where you are sharing with 6, 7 other patients as you're seeing them? At the provider level, there is a lack of interest, even during training. You ask the undergraduate, will you want to pursue psychiatry after? And it actually becomes a big joke that you're taking psychiatry, that you're a lazy doctor, you're not a very smart one who will become a neurosurgeon. So mental health is seen as the one where, people, so it's one of the things that I faced when I was applying for my psychiatry residency. And mental illness stigma, it's a big deal even among providers, and also a big challenge within our communities, and a lack of clarity of provider roles. Are you expected to actually offer mental health services? And that's a big issue in our clinics. At the patient level, yes, we're talking about mental illness itself does limit your autonomy and ability to actually seek the service, and so it's a big problem with mental health. And poverty, even if I send you to a specialist, you'll not afford the specialist. Mental illness stigma, as I mentioned, that's another big deal with seeking services, and people will shy away from expressing the need for mental health services. And an interesting one is preference for specific providers. And in our kind of setting where you're going to meet whichever provider you meet in a day, you don't have your family doctor. You come in and say, I'll not tell this one what I'm facing, and that's a big issue because I prefer the other one who was here, and probably that one has now been moved to gynecology unit or something else, and it becomes a problem. So how do we plug these gaps? Several ways. We've asked people to think about ways to plug them, and many of them think, can we do self-screening? Can adolescents just screen themselves? And the advantages to that, it's more private, you can be more open, especially if you're dealing with issues that may be stigmatized. But there are challenges to that. the provider says, I want to see you as you answer the questions and we have a discussion. That way I'm able to help you because I'm also seeing your nonverbal cues. And there's also the adolescent saying, I need this prompt, I need the discussion with my provider so that I can think about the questions that you're asking. Telehealth, especially when it comes to screening and so on, it has its advantages. The counseling can be done when you're at home, so we reduce the costs. The counseling can, or the screening, including even screening, can be done when you're home, so that when you come to the clinic, we know was a challenge. But there are also issues. People are saying it won't work because in screening you have to assess the client's face, and that's another issue. I'm seeing you over the phone or via Zoom. I really don't get a feel of whether the intervention I'm giving is really impactful. And of course, this involves some data, some airtime, and that costs money too. Task shifting is an interesting one, where you train people of lower cadre to offer the services, and so you increase the number of people who can do this work. The challenge, of course, is that you may be shifting away the responsibility from the people whom the patient wants to see. And that has been a big issue. You have people who have competency, and then after some time you say, this task will be done by someone else. And then a new cadre has to start developing rapport with the patients and the same competency. So talking of task shifting, we are thinking, we rolled this study to assess a brief transdiagnostic psychological intervention, which we call PROACT. We know that the full cognitive behavioral therapy, interventions can be quite long, requiring people to come many times to the clinics, maybe 12, 16 times. And that is not possible with adolescents, especially with school and they're early in work, where they'll not get many offs. So we are trying to see whether this is one of the interventions, a short intervention that could have nearly as good outcomes as we know the big CBTs do. We already have that evidence. So we are trying it on one-on-one, delivery mode, in person, but for some who are not able to make it, we're also doing phone delivery, and we're training lay providers. So your peers and so on can offer this intervention, and it's very short, only maybe 4 to 5 modules, and you can come in either weekly or 2 weekly or monthly, depending on availability. And now we are recruiting. We've recruited about 500 adolescents, and now we are doing the follow-up following the intervention, which we are doing within 6 months. And we are seeing interesting results. While everybody whom we enroll has a PHQ-9 or 5 and above, we are seeing quite a lot of comorbidity with anxiety symptoms and also trauma symptoms, which we are hoping the intervention will address. And we're also seeing about 20% of the adolescents having challenges with alcohol, and only about maybe 4% with other drugs. And the next stage, we are hoping, we are applying for grants. This is the conclusion. And we are hoping that actually we could take up the friendship bench. The friendship bench, very good, evidence for community application. And we are hoping that we can shift, place this friendship bench intervention within our primary health care. And that is, the community units and primary care, facilities. That is level 2 to level 4 for Kenya. And see whether we can have population level impact. And so in summary, we have high burden of common mental disorders, with the screening and referral practices falling short of recommendations. Whether we are dealing with structural or patient-level barriers, we require some innovations for this. And the easy ones, self-screening, task-shifting, telehealth, we may think they're easy, but they do require a lot of work to actually, actualize. And we are hoping that integration of these interventions in the community and primary healthcare settings may be just a magic bullet. Thank you.
Thank you very much, Dr. Mugo, for your insightful points. I think it also serves as a reminder that although we differ by culture, by background, by even geographical location, the problems surrounding mental health stay the same. And while they affect individual patients, individual youth, we must deal with them as a community. On this note, to wrap up the session, I would like to invite Dr. Patty Gonsalves from the Youth Mental Health Group Sangat India in Delhi. Dr. Gonsalves will tell us how to leverage digital storytelling in order to improve youth mental health. Dr. Gonsalves, floor is yours.
Sorry, I'm the shortest person. Thank you. Thank you, Sukarya, for having me. I think this session could not be more timely, mental health stress and digital influence, because in just one generation, young people's social worlds have shifted into almost entirely digital spaces. So it's a very interesting time to be alive. This is a shift that has connected us in really incredible ways, but it has also coincided with increasing levels of anxiety, of depression, and loneliness, especially amongst young people around the world. So today I want to explore this paradox, which is how digital technologies can both help as well as harm. And I will briefly touch on how digital mental health has evolved over the last 30, 40 years, what the data tells us about what young people are experiencing, and what many researchers and people around the world are actually calling the anxious generation. And finally, about how storytelling, which is something that is as old as humanity, could be a very powerful digital tool for young people's well-being. So to understand where we are, it's helpful to see how digital technology has evolved. In the 1990s, 2000s, the internet was primarily a space to get information. This was through very kind of static websites that explained mental health problems, mental conditions, and forums like chat rooms where people were able to share experiences, often using anonymized identities or pseudonyms. By the 2010s, smartphones had really changed everything. Suddenly, you were seeing a burgeoning of mental health apps, of mindfulness platforms, online therapy portals, and very importantly, social media that made an appearance and really gave young people and people at large a space to connect and a space to share vulnerability, often for the very, very first time. Then the pandemic around the 2020, which really accelerated teletherapy, digital tools, digital self-care. And today we're seeing the next wave, I know this will be explored more tomorrow, but of artificial intelligence driven tools that are offering very personalized mental health support. The evidence and the research, though, has not caught up with this very fast pace of the evolution of the technologies themselves, and there are numerous reviews of various kinds, systematic reviews, meta-analyses, umbrella reviews, that all seem to point to a kind of similar conclusion, which is that we still don't have enough evidence to really understand how these technologies are helpful and the ways that they are harmful. And I will try to summarize some of this research for you. Coming to young people specifically, and this is the really kind of, I would say, like puzzling piece of the puzzle, there's many large-scale surveys, particularly from high-income countries like the UK, the US, and Europe, that show that rising rates of anxiety, depression, and self-harm among adolescents began to climb sharply around 2010. This is not a coincidental, random timing. It does coincide closely with the widespread adoption of smartphones and of social media. This is a very interesting book by a social psychologist, Jonathan Haidt. And he argues that we have moved from what he calls a play-based childhood to a phone-based childhood, and suggests that we have really rewired adolescence, replacing unstructured outdoor play and face-to-face connection with screen time, with curated identities, and algorithm-based validation. It's a very provocative thesis in the book. Not everyone agrees that phones are the sole or the only culprit, but things like social changes, immense academic pressure, especially in our setting, and even global instability, they do play a very big role. But what is clear from multiple studies is that this digital immersion has changed how young people develop both socially as well as emotionally. They're constantly connected, but sometimes deeply lonely. And this loneliness, paradoxically, is happening in the most connected generation in history. So what's really happening on these platforms? This is a kind of very high-level summary of the research that's out there. So on the positive side, as you see on the left, social media has been really revolutionary in building mental health awareness, in offering a space for young people to share their stories, their narratives, to find communities of support, particularly for young people who face experiences of marginalization. This is really relevant also in peer-led communities online, which can really be lifelines for young people who can't seek support elsewhere. There's also a range of risks, particularly for young people who engage in what's called problematic social media use. For example, cyberbullying, social comparison, FOMO, the fear of missing out. Constant comparison, exposure to sort of idealized lifestyles, and also the addictive design of the platforms themselves that can take a heavy toll on young people's mental health. Heavy users of these platforms do report higher rates of anxiety, depression, and sleep disruption in particular, and body image concerns, especially for young girls. Keeping some of that in mind, I want to share a small case study in my last 5 minutes or so, which is considering some of these benefits as well as the risks. We designed a platform called It's Okay to Talk, or It's Okay Baat Karo in Hindi, where we asked a simple question to ourselves, which was, what if young people were given a safe, creative space to share their mental health stories online in their own voices? The idea became this platform, which was at the time in 2016-17, one of the first storytelling platforms that was focused on young people's mental health in the country. And we share stories here in Hindi and in English. The stories focus primarily on anxiety, depression, and a range of other mental health concerns. And this is a platform that has been co-designed, meaning we have worked very closely with young people who have these personal experiences themselves in designing and maintaining this platform. What actually happens on the platform, these are a few screen grabs here. But the website features a story library where young people and users can filter through, they can personalize what they would like to read by topic, by format, audio, video, text, etc., and the kinds of storytellers or contributors on the platform. Engagement is also promoted through the use of reflective tools that encourage young people to identify adaptive coping strategies and then apply these to their own lives. All of the content, as I mentioned, is in Hindi and in English, and every story is reviewed by a member of our team or a mental health professional to look at things like safety, sensitivity, and also all of the contributors here consent to their stories being used. These are just a couple of snapshots of what a story looks like. I'll let you read them in as much as you can, but this is a story by Lakshita. She's 19, and she's talked about it's a poem about her experience of depression and self-harm. And this is a story by a 19-year-old who has talked about their experience of receiving counseling while living with ADHD. Last year, with support from Grand Challenges Canada, we were able to pilot, evaluate this platform, and we worked with students and young people drawn from universities, from high schools and NGO community settings. And we tested a model that combined very brief peer support with use of the It's Okay to Talk website over a period of a month. And what we found was that engagement was very high, particularly among university students for reasons that you can guess, things like autonomy with having mobile phones, freedom, having access also to a mobile phone because of their age. And on average, we saw that participants read about 4 stories. This lines up quite well with adult studies from other countries. But most importantly, we also saw some measurable improvements in mental health symptoms, particularly anxiety and depression. While young people appreciated the peer guidance, attendance was quite uneven, and what really stood out in the data was that they appreciated the stories themselves the most. They described what you can see on the right. Those are some of the mechanisms of the intervention. Described things like feeling less alone, their stigma reducing, being able to identify suitable sources of help, or stress or coping strategies. So the big takeaway here, even though this is work that is just still at a pilot stage, was that storytelling is not just a means of communication, but it could be a very potent intervention. Till date, we have had about 200 plus stories on the platform. We've reached over 27 million users, particularly through partnerships with larger social media platforms like Facebook and Meta and Instagram. And offline, we've been able to engage with thousands of young people through in-person activities. So in closing, where do we go from here? And these are a few recommendations for different groups that are affected by this kind of emerging area and challenge. So for researchers, for developers, creators, the answer lies in co-production and co-design of these platforms that really factors in some of the benefits and the risks that we saw earlier, as well as testing interventions rigorously, publishing both things that are going well as failures, things that are not working, and building in safety mechanisms for young people as well as referral pathways. For parents and carers, this means less surveillance, more communication, encouraging, for example, phone-free time, protecting sleep, preserving sleep, and also modeling balanced digital use. We're seeing big changes implemented in countries like Australia, Finland, Denmark, where they are banning the use of social media for young people under the age of 16, for example. For educators, similarly creating phone-free learning environments, teaching well-being digitally just the way that we teach other life skills or nutrition, not social media but digital literacy, and integrating projects like storytelling, peer-led support into classrooms to also build other kinds of resilience and empathy amongst young people. And finally, the platforms themselves, and this is a discussion for another day and perhaps another forum, but the platforms themselves have a duty of care. So algorithms should not reward outrage or self-harm content. Safety by design, age-appropriate content, age-appropriate features, and transparency are quite essential. Thank you. And just to say, this work wouldn't be possible without the larger team behind it, as well as very large numbers of young people who've been part of the work that I just shared with you. Thank you.
Thank you very much, Dr. Gonsalves, for sharing with us that it is okay to talk about these things. But I believe I've spoken enough for this session, and I would hand over the conclusion of this session to my co-chair, Ms. Rashmi Singh. Ms. Rashmi Singh, please share with us your observations.
Sure. Thank you. And I must say that I was supposed to have been here in the last session itself, but I got the benefit of actually being a part of both the sessions. And there is definitely an connection between the two, because in the last session, when we were actually looking at the rights, power dynamics, gender, and the sexual and reproductive health rights, related with adolescent. Now the connection today with, what we discussed in this particular, session, which talks about the child mental health, the maternal mental health, and the adolescent mental health, has a huge kind of bearing on the entire health and well-being, of particularly adolescent, which are the focus, in during the course of discussions today. And I do feel that this particular session, where three very, very important aspects have been highlighted, bring, volumes of insights which are actually not just relevant in one particular context, but it's actually very relevant in most of the context. They are very generic in most of the context. And I would just kind of try and just bring my personal experience first on this topic, one of the personal experience, because obviously we did not have the time. When I went to a beautiful place of Andaman and Nicobar Islands, around, I would say 6-7 years back, and because last 3 years I was in Jammu and Kashmir, and I've just come back to Delhi. So, now traversing between Delhi, Andaman and Nicobar Island, Jammu and Kashmir. Now, what is it which used to bring a concern when we were looking at the different government schemes and programs related with the children, related with women, related with adolescent girls? It was actually a state of their emotional well-being. It was actually a state of looking beyond their physical well-being. It was actually a state of looking beyond what's just supposed to be, tangible outcomes, in terms of giving nutrition and then, measuring the numbers to whom you have been able to give nutrition from, say, government programs like the Anganwadi services, which you would be well familiar with. In India, we have this huge platform, which caters to mothers who are pregnant, mothers who are lactating, mothers who give birth to children, so the infants. But at the same time, we do realize that there has been a need for looking at mothers not from the time that they conceive, but much before that, to prepare them for motherhood, to prepare them for their own, reproductive health and rights. And what more and what better than preparing them not just physically but mentally. And so we also realize that in this huge program, which looks at, catering at the community level, going to the various like village level community structures where households are mapped. Every household is mapped, listed with the number of children, and then brought into the intervention of the various kinds of healthcare services which through Anganwadi services in India we provide, which also relates not just to women and child development alone as a department, but it brings the integration with health department for, say, immunization, for antenatal, postnatal checkups of the mother, and also the nutrition side. So all these things, combined together for the mother and the child, for the well-being as a whole. But one thing which we realize today that we are missing out is this particular intervention which was so prominently talked about, involving the community. And education, of course, is a huge, big stakeholder, when we talk about, integration as a whole about the services. So education, right from the early childhood education to the entry into the mainstream school education at the early stage of the child, to carrying on as an adolescent. And so here when I looked at some of the takeaways from, the first talk which was rendered by Dr. Kirk Tickle, if I'm rightly pronouncing the name, that, bringing the maternal mental health with a strong direct correlation, which you said, with the child's mental health, and how much it has also related to the fact that the hospitalization, the increased hospitalization of the mothers vulnerable, that was also something which, as research brought out, that those, were the same mothers were prone to much higher degree of mental health issues, who were hospitalized, bringing the various, causes, where one approach which you talked about as a friendship bench approach, where you have spoken about the social support mechanism, where you've spoken about the role of community volunteers, you have spoken about the role of behavioral therapy, so this is something which I think has a key resonating also from the other approaches that we spoke of. The friendship bench approach with, a very low-cost intervention model, but with a direct correlation on the child health outcome and, of course, the adolescent health outcomes. Dr. Jiten Nagpalji, when you spoke about, again, the difficulties in right from the time of identification, early identification, to the intervention at an early stage and the serious consequences which, are therein. Again, I'll bring my experience of Andaman when you spoke about suicide. In a place like Andaman and Nicobar Island, with such a beautiful, lovely place, I realized when I went there that one of the biggest challenge was one of the highest rate of suicides over there. Why? And then, you start engaging more on the subject with the community. You realize that, again, this fear of, probably not being able to talk and being, faced with people who are judging you because there's so much of technology has been penetrating, talking about like bringing them with areas which are like so far hitherto unknown, but children were scared whom to talk to. In the process, lot of teenage pregnancies in the process, lot of stigmatization happening, lot of broken marriages happening, and all that resulting in very high suicide rates. So again, across different spectrums, when we measure things, we realize that it's something which today we are battling as a society, looking in terms of the outcomes of not just suicides, but also high number of drug users, which in a place like Jammu and Kashmir, I was battling with, which again had its own kind of very, very alarming, set of repercussions as to children, youth, whom we are trying to integrate in the mainstream system, and yet, they are not in a position to really be receptive enough to what our education curriculum is providing. As Dr. Nagpal said, NEP, it does provide us with enough tools. But, we need to really look at the societal condition, the community engagement, the conversation, happening amongst the youth, amongst the peer group. And you did talk about creating an ecosystem, Dr. Nagpal, for the mental well-being in university, through especially the universities and schools, by integrating in the curriculum through a professional management, being not just a part of educational curriculum, but it was interesting that, making it a part of health curriculum with peer mentors. And, this entire notion about creating student leadership, and through better training of the peer groups, faculty, creating a feedback mechanism. And the last, I will not miss out on this word because I like well-being ambassadors, which was said, that the peer group or the volunteers, given a term like a well-being ambassador, right from schools and universities, and the kind of Vatsalya program which you have experimented with in the past. So that shows another promise, because while we are looking at challenges, it's very, very important to be talking about the promises which we have, the opportunities that we have, the good practices that we have, which needs to be scaled up. And Dr. Cyrus, towards the end, talking about, again, the Kenyan example of 30% of the total burden of disease, depression, anxiety, trauma, accumulating to 30% of the total burden of disease. Am I right? So this is so low, and then the concern about the low investment in the mental health care. Less number of psychologists, psychiatrists, and the high burden prevailing amongst the adolescent particular. And one of the main factors being, as he sums up, poor quality of life, and of course, like many other related factors. And talking about the implementation challenge, which again cuts across that, the policy is there. I was happy to see that you spoke about the policy being there in terms of maternal health policy and package of care which has been created for adolescent care, which is again something which is a good takeaway, that at least a policy which is localized has to be there. But of course, in terms of the mechanisms of implementation, all the challenges that we keep seeing, how do we plug those gaps is something very, very important. And especially when he talked about the barriers at the provider level. So it's basically the supply side and the demand side, both which he speaks about, in terms of shifting of tasks, which he speaks about, brought out from the research. The patient level barriers, the community level barriers, and then coming up with an approach of, say, telehealth, medicine, telehealth system, phone delivery system, and also talking about, integrating mental health through the primary health care and the community-centric approach, which, of course, resonates across all, that the community-centric approach is something which is very, very important. So I think for all of us, it's very, very important that when you look at, again, especially the adolescent health part, and going towards maternal health and going towards, the well-being as a whole for children and, mothers and adolescent girls, these aspects are given adequate attention. And last but not the least, I'd like to add that over this weekend, Saturday, Sunday, at the Supreme Court, we had a 2-day, full day of talk around, again, the rights and concerns, challenges in for the adolescents' development, their rights, and overall, looking at government schemes and programs which are catering for the adolescent and the role of various stakeholders therein, and especially to bring that convergence and that ownership, how important this segment is. And as me and Suraj were talking, for the entire SDGs, it's not just restricted to one SDG alone, but it cuts across this concern across all the SDGs. Thank you once again for giving me this opportunity. Thank you. And of course, Dr. Thomas, I would thank you for bringing such a good context and moderating the whole thing so well. Thank you. Thank you.
All right.
Can we take a few questions? If you comment?
But certainly, I would like to reiterate that they ought to be brief, but we can certainly take a few questions. Could we get a mic to the gentleman over there?
Okay, this is the question that directly goes to Dr. Jitendra Nagpal. What we have seen in couple of years, there is a substantial increasing of the suicide in the higher educational institution, particularly the vulnerable group, the marginalized groups, the downtrodden. So in this context, how we can address the issues of diversity, this cultural diversity, social diversity, and the gender diversity to create more inclusive environment to address the mental health and the suicide. Because if you see in the national education policy, which talked about the inclusive environment, and substantially in your lecture also you told in the Kharagpur, and there are many more institutions, this kind of incidences is increasing. So how the will be address these issues? Thank you so much.
Thank you, sir. Undoubtedly, it's a multi-pronged approach, and you're aware that now government, both in terms of the judiciary's prompting, the Supreme Court has taken a very close look at the disastrous self-harming or number of suicides increasing in the institutions across the country. To begin with, the question has come up, undoubtedly what you said. Some of the role model institutions can be hallmarks of what we were just sharing, Dr. Kirk and Rashmi ma'am, myself, can be actually role models for a holistic human development. Why just about higher education? Higher education is about holistic human development, because you are embarking on the life's journey after that for next 50, 60 years. So, two things are happening right now. The University Grants Commission, taking care of 1,300 universities in the country, has got a complete systemic approach to a mental health policy started now, which will invite attention of a structure, function, monitoring and evaluation of the mental health care support systems in all Indian universities. By the turn of the year or by the middle of next year, you will probably have a gazette, a policy coming from the Supreme Court as a non-negotiable policy for the country. So that will be a huge step forward. It is already going on, you know that. And then today's paper, kindly read it today, and they have had a discussion, but many of the institutions yet to respond. So it's a good thing happening, but the tragedy still remains. We're just discussing how the high IQ and the low EQ, or the imbalance between coping skills and very high achievement scores in the universities, are a dilemma. And we all know the reasons, whether it is social diversity and discrimination, ostracism, whether it is ragging issues which are very common. Now the law is there for prohibition of ragging, but still there are cases reported in these examples. Secondly, it could be about people who are vulnerable, and all of us are vulnerable as human beings. Who says the brightest of the people are not vulnerable to mental health conditions? The world has some of the best examples in celebrities also. So can we have a system of identifying what ma'am just said, early identification, irrespective of any vulnerability? The best of the institutions can do the best in early identification, why not? So the structure of having a fully qualified, independently standalone mental health system, having at least 500 students and one psychologist or a mental health professional inside the campus 24/7. So counseling centers are getting established. Last year, IIT Hyderabad, one of the new IITs and a very, very prospective research-based IIT Hyderabad, is the one to start with the national conclaves on mental health. We finished one last year. More than 100 institutions participated. They had their exhibitions on mental health, what best practices. Now it's going to happen in one of the premier institutions in November. There's a meeting today, in fact, at 8 o'clock around that. So it's good things are happening. The mood is changing, but then it cannot be just taken as a sideline. जो आपने बताया अभी, it cannot be taken as a sideline. It's a non-negotiable aspect of running any educational institution. Without mental health, no education. It's coming to that. So hopefully we'll see more results in 2 years' time.
So this is Dr. Parthi from Institute of Biohospitals, and this is with regard to Dr. Nagpal's presentation and statement. The mental health is concerned for adolescents. It need not be only kid-centered. It has to involve the family. I am not here to say it's community involvement. It has to be family-centered. Just because there is an example, because we come across a lot of patients, adolescent patients with a lot of issues, right from anxiety to mood swing to suicides to love and lust conflicts everywhere, and even courts are full of these problems. And I would like to represent, there is one thing to all the parents, don't shy away from involving into kids' problems. Number two, the kids, especially with well-educated urban Indians in almost all cities and metropolitan cities, they isolate the kids from 13 years to 18 years as a refugee camp trainees, and they give them education and food for eating, nothing else. They don't involve them in social activities. They don't involve them in environmental activities. They don't involve them life event activities. As a result, they become sick mental patient. They are good in scoring marks and they are good in earning money, but they are highly vulnerable and victims of the society.
Yeah. So, one thing which was mentioned by someone was the school management committee part, right? And the school management committee, in terms of like getting also the parents involved. But in intent, yes, practically, very difficult to get the parental involvement. And so I think this needs to be the parental involvement, with the children. As you said, that the family involvement with the children, especially to see early signs of the child getting quiet or not wanting to come to school, or a dialogue between the teachers and the parents. It is very, very important. And one thing which I would like to share, that digitally, the role of the data and the connect between the parent and the department, whether through Anganwadi services of early identification, which happens, it is supposed to happen. So the Anganwadi services in context of India, and the schools in any case for all context, and the parent and the duty bearers, so to say. So this digital connect, I'm aware of the fact that there are portals designed for this. So there is real-time report sharing also, because at times it happens, and we had the Delhi Commission say for the protection of child rights, the DCPCR, getting that red flag data from the schools that the child has not been coming for so many number of days, and then the counselors actually reaching out to that family, why is the child not coming, and that was the early sign, and then going into, whether there's been, some kind of what trauma, what is the factor leading to, that dropout and anxiety and depression. So just wanted to share that, there the technology and the human interface both have a role. Technology only, to communicate the data on a real time, but no substitute to the human interface. I'm aware that there are tele-therapies happening through, say, Wim Hof, Samvedana, and you'd of course know it better, in terms of the counselor responding to calls being made, or our helplines our call centers. So there are helplines, say 108 for children, and there are helplines for women. Yeah, but all the helplines, they will not be responding to, the level of counseling care, but they are meant to create a referral system. So they're probably like these, tools can be used better. Thank you.
I don't want to delay the close of proceedings, but is there a role, is there any body of work on happiness and mental health? Because conversations on mental health tend to become, sorry to say, a bit morbid and negative. But is there a place for happiness promoting activities, including through cultural performance, to address this entire issue? Because there is a perception that in the process of addressing mental health, we should not become a nanny state. Okay, adolescent is a very diverse group. Okay, it's just a generalization. You cannot confuse an age cohort with a state of mind. So is there a body of work on happiness and mental health? I'd just like to know that.
I'll just quickly get started. I'm not aware of any specific relations between happiness, but I would like to point you at the most recent definition of health put out by the WHO. You may remember it used to be the attainment of a very high level of health where everything is nice. But now we've moved away from it and we have more of a promotion of the ability to cope with the challenges that life throws at you. So I would say that the focus is there, and there's definitely a mounting level of evidence, including with physical activity as it promotes well-being. These were just few short elements of answer. I can hand over to ma'am for more detail.
Yeah, there are curriculums in different names. There are curriculums designed. I'm aware that especially in Delhi, there have been curriculums specially designed for creating this, happiness frameworks. And as I said that, there over the period, there are different names by which, those can be interpreted and seen, but more of activity, fun, play. And, there, of course, it's not like measuring the, the literacy level, but it's actually measuring the emotional health in terms of being equivalent to happiness, yeah. So it's EQ as a whole, emotional quotient, because it's not like, today the discourse has also moved from, say, just talking about mental health to emotional well-being. Yeah, so it's not even health, it's also the question of like emotional well-being, which for that matter relates to all of us at every life cycle of our state. But earlier we start, putting this into the notion of each child, being growing up as a happy individual. I think that consciousness is very much there, but structured frameworks, I'm not aware where all they have, how much NCRT has integrated, how much CBSE has integrated, how much, in NEP it has been integrated. Definitely there's an attempt to do that. Thank you.
In fact, it may be right to look at it from the diversity of activities available in prevention and promotion. Because agreed that any discourse on mental health by and large tends to, by default, deviate into morbidity. But then if you saw the ecosystem which the government is now working on, the level 1 and 2 actually are about diverse activities like life skills or emotional literacy through diverse activities which students love to do. It could be role plays, theatre, drama, storytelling, nukkad nataks and debates, singing, Indian classical dance and mental health. I'm surprised. We had a event last year and we had 230 entries from all over the countries about all major 16 Indian classical dances, and the connection was about positive mental health. How Kathak and Bharatnatyam are innate. So you could see the diversity coming in, and I'm sure ma'am mentioned about Vatsalya. What is Vatsalya? It's about the mother and child care that leads to a different celebration. So celebrating mental health through diverse activities is a happiness curriculum also. We don't have to wait for morbidity to come and celebrate role drama and nukkads.
Just breaking the protocol, but I'm very tempted to add that one big takeaway for me is that in my dual hat as the Secretary Art and Culture, it's a good takeaway. That one can contribute actually, through art and culture dimension also, to be looking at what Suraj just spoke about. Thank you.
Dr. Thomas, would you like to just conclude the session?
With great pleasure. Maybe I can bank off what was just mentioned in Sir's question, and in fact, the relationship with happiness. And for that, I would like to conclude on the example of Finland, which is a northern European country that is oftentimes dubbed the happiest country on earth. It always comes on top in all of these rankings. However, once one takes a look at the data in more detail, Finland is actually very high in the burden of self-harm, in the burden of suicide, and in the burden of addiction. So there might be much, much more than meets the eye. Again, as was so interestingly put by all the panelists here present, I think mental health is immensely complex and immensely integrated in a lot of different areas of interest, ranging much beyond healthcare, much beyond education. So it was a real pleasure for me today to chair this session and to chair such an interesting panel of experts to, let's just say, have a conversation on mental health. And remember that it is, as Ms. Gonçalves mentioned, it is absolutely okay to have a discussion about these topics. On these words, I would like to thank you for your attention, thank the organizer once again, and wish you a very nice evening.
Thank you to our speakers for their powerful insights. This reminds us how caring for mental health is central to building a generation that is resilient and confident and ready for the future. May I please request Ms. Meera Satpathy to come on stage and hand over the plaques to the speakers and for a group photo. The speakers are requested to stay on stage for a group picture.
I cannot hire a mental health specialist for my pregnant girls for one trip is 6,000 rupees. One trip. And I don't even get that. I don't even know if she's the right one. I don't even know if she can really come. So I have 1,000 questions, but I'd still like to give a plaque.
Thank you so much for your contribution, Ms. Rashmi Singh.
Friendship, this thing which was for everybody. I don't know how to integrate cards for together. We try and bring it together, and I would be happy to have something done in it. Go in it, just sit down. Where is the sitting? A lot of chairs, but there is probably we are going to very soon.
May I please request the audience to put their hands together for the speakers.
Thank you so much. Thank you. Whose is this?
Ms. Rashmi Singh.
I'm so delighted that you could make it, and she's such a lovely speaker. And
Dr. Kirk Tickel. Dr. Kirk Tickel. Please, can we please put our hands together for the speakers, please?
I'm looking like a banyan tree right now.
Dr. Jitendra Nagpal.
Oh God. I have been here since 30 years. I'm working for the first time. Otherwise, I've heard you. We have to take it back. Thank you so much. Yes, I know. Is it? So don't get mentally disturbed.
No, I have a therapist.
Thank you, sir. Dr. Cyrus Mugo.
Cyrus, you have to come to the front. There. Sorry, what did you say?
And finally, Dr. Patty Gonçalves. As we close day one, it is now time to hear the closing reflections May I please request Ms. Meera Satpathy, Chairperson of Sukarya, and Ma'am, and Professor Asha Kapoor Mehta, Chairperson of the Center for Gender Studies, who will sum up today's discussions and connect the key learnings to us.